had before was around 150. And I think that tells us that sleep affects so many of us. For HIPAA reasons, I'm not going to ask you to raise your hand if you're here for your own sleep issue or for a loved one, but I suspect most of you want to learn for someone in your life, and I think you're in for a treat today. We are very lucky to have Dr. Donald Bliwise with us today. His title and program are on the slide, so I don't need to repeat it, but I will tell you he has been at Emory for 30 years. He got his doctorate at University of Chicago and his postdoctorate at that school on the West Coast. You know, if you're not going to go to Emory, you can go to Stanford or Harvard. He's been doing sleep work since the 70s. So he was in it before it was popular, and he is known to be an expert at the sleep clinic, and we're very grateful to have him here. You are all muted. If you have a question, please put it in the chat. And if you're not terribly familiar with Zoom, roll your mouse over the bottom of the screen and some navigation buttons will appear. And one of them is the chat, and you click the up arrow, and then you can put your question in the chat. And I will be monitoring them throughout the session. Because we do have such a large crowd, we're already at 85 and we've hardly gotten going. I just want to remind everyone that this session is provided as educational for you. It's information we want to give for you and your loved ones and your family so that you can have more intelligent, productive, efficient conversations with your healthcare provider. With, over 100 people on the session, we're not going to be able to answer individual issues. So if you have a question, please try to phrase it as broadly as possible so that it would apply to the majority of the group. And I'm going to put into the chat the phone number and the address of the Emory Sleep Center. I am a patient of theirs. I don't mind sharing that with HIPAA. They're very helpful. They're very lovely to work with. Several of my family members have been there. We've all been treated for different things. It's amazing how much sleep covers, but we're gonna get into more with that with Dr. Bliwise. So at this time, I will turn it over to Dr. Bliwise. And thank you so much for being with us here today, Doctor.
Andrea, thank you so much. Very kind of you to introduce me in that way, and I hope to provide you all on the Zoom today with information. Maybe some things some things are new, but hopefully you'll come away a little more informed. I first want to just indicate that over the course of my career, I've had great support from the National Institutes of Health. These are some of the grants that I've had and been involved in. I've also been a consultant to some companies in the pharmaceutical industry, and so you all should know that also. So here's the basic outline for the talk. I'm going to talk about both subjective and objective changes in sleep that occur with aging. Talk about them in more general terms, and then I'm going to talk a little bit about the functions of sleep. This is a whole lecture in its own right, and it's a fascinating issue. I'm just going to touch upon a few things in that domain, but not get into that too much. I'm going to talk about what people can do to try to improve their sleep, and sort of breaking that down into traditional pharmacologic agents, supplements, and also behavioral approaches, which I think are sometimes lost when we talk about how we can try to improve our sleep. And then I want to end up with some specific disorders of sleep that are common in the sleep clinic here. And I would be remiss really if I didn't talk about those. So that's the basic outline for the talk today. And I want to start by talking about self-report. What do people say in different age groups if you ask them about their sleep? So age is represented here. This is a busy slide, but it does make a lot of points, I think. So I'm going to keep it up for a minute. These are the different age groups here, 1 to 6, and you can see them on the x-axis here. 6 being the oldest age group. The y-axis on this graph is the prevalence of various sleep complaints. And here are the complaints up here. Difficulty falling asleep, difficulty staying asleep, waking up too early in the morning, and sedative hypnotic drug use. That's what we call, it's the general word for talking about sleep drugs. And a couple of points really to be made here. First of all, as we get older, particularly difficulty maintaining sleep becomes very, very common. And as a matter of fact, by the time you get to age 65, it's really more common to have problems with sleep than to not have problems with sleep. And that's indicated by the prevalence figures here. 50, 60%, even up to 65% may have at least a mild form of the complaint or the symptom of difficulty maintaining sleep. For those of you who are very OCD oriented and want to know the difference between the speckled lines and the dot, these striped lines down here, this includes a mild form of the complaint. And so if you can include mild sort of problems staying asleep, it's really common for people as they get older to have this as a complaint. And this is what people say about their sleep. Women generally tend to have a few more sleep complaints at every age. You can see that relative to men, males and females here. And I've been sticking with difficulty maintaining sleep because that is by far the most common problem that we see with sleep. But we also see a slightly lower prevalence of problems falling asleep at the beginning of the night. That's what this refers to here. Not necessarily as much of an age effect here. There's still a gender difference, with women generally having more problems with difficulty falling asleep. Early morning awakening, which is really sort of a subset of difficulty maintaining sleep, also shows the age effect. Instead of the hypnotic use, not surprisingly, shows an age-related increase as well. So this is a very typical survey. This one was done in Texas many, many years ago. There have been literally hundreds of surveys asking populations about their sleep, and they all show pretty much a pattern, give or take, pretty similar to what you see here. So let's talk about what's involved in what are potentially the associated factors with poor sleep. And medical conditions certainly are high on the list, so are psychiatric conditions, but the purpose of showing you this data, and I do show a lot of data slides. I have some pretty pictures too, but I'm a data-oriented kind of person. So if numbers speak to me, I hope they speak to you as well. But these are odds, the odds of having, for example, mild insomnia if you're depressed, if you have had a heart attack, if you have angina, if you have COPD or pain. And what these data show is that you should never assume that having insomnia means you're depressed. If you are depressed, or dysthymia would be another form of depression, yes, you're more likely to have insomnia. But if you hurt, if your back hurts, if you have hip pain, you're also more likely to have insomnia as well. And if you have heart disease and chest pain, you're going to have a risk for insomnia. So many, many medical and psychiatric conditions will predispose you to have poor sleep. And this is just mild insomnia. This is a more severe form of the symptom as well. But there are many reasons why the prevalence, for example, that we saw in the preceding slide is so high. And this gives you at least some of them. One that's not well appreciated is shown on the next slide. And this is something that's been of particular interest or research interest of mine over the last 10 to 15 years, is nocturia. That is, getting up to use the bathroom at night often disrupts sleep because people have trouble getting back to sleep afterwards. And this is a survey that was done a number of years ago where we asked everyone in the survey a checklist. We mentioned each of these conditions and asked them how often it disturbed their sleep. And what was really interesting and somewhat surprising is by far the symptom or the condition that is most strongly associated with sleep disturbance and not sleeping well almost every night was waking up to pee. And so that was a real kind of surprise. And believe it or not, this hasn't been researched as well as it, in my opinion, it should be, what the causes of this are, and certainly what the treatments are for it. But it tends to be quite a salient and important issue. So these are some of the symptoms that people have, or some of the reasons that people report having poor sleep. But that's all self-report, right? And so when we study individuals in the sleep lab, we study them with a technique called polysomnography, and that allows us to look at brain waves and things like breathing and movement and so on. And the purpose of this slide is just to give you some sense that the brain waves change from the awake state, where you have a very a low voltage in terms of microvolts, that's this axis here, and a fairly high frequency signal. As we fall asleep, the EEG tends to slow down, the frequencies get slower, and the amplitude gets higher. And that's the transition we talk about in non-REM sleep, from awake to stage 1 to stage 2, and then what we now call stage 3 and 4, or delta sleep. Interestingly enough, REM sleep, the stage where dreams occur, is characterized by a very fast EEG pattern. It doesn't show the deep delta waves that we often see in stage N3 sleep. But of course, REM sleep is characterized by rapid eye movements, and that's when dreams occur. If you look at how the sleep patterns change with age, this would be a typical middle-aged adult and a typical older adult. And these, what we call hypnograms, this is time or hours of the night here, not necessarily clock time, but elapsed hours of the night. And these are the stages of sleep here. And you can see in a middle-aged person, these would be people without major sleep problems or sleep complaints. The individual falls asleep and they quickly descend into the deeper stages of non-REM sleep, down to stage 3 and 4 here. And after about an hour and a half, the sleeper enters REM sleep, which is the orange bar up here. You can see REM sleep occurs periodically, approximately every hour and a half, give or take, throughout the night. In the older person, you see a few different kinds of patterns. First of all, the older person might not make stage 4 sleep. They have less deep sleep. They may go into REM sleep even a little bit sooner during the night. And then really what's most distinctive about the sleep patterns of an elderly person is that they wake up more frequently towards the end of the night. So while the younger or middle-aged person generally may stay asleep, maybe they wake up once or twice to use the bathroom, for example, the older person wakes up much more during the night, and there's more alternation between awake stage 1 and 2 with a little bit of REM thrown in. So these are typical hypnograms that we see as a function of aging. I just want to focus a bit more on the decline of deep sleep. That's the delta sleep with the large delta waves. This declines quite early on. It's one of the earliest markers of aging in the nervous system that we have. This is a study which really included a wide range of ages from the teenage years up to over age 85, and you can see N3 sleep, which is the deep stage of sleep. That's a percentage expressed as the percentage of total sleep tends to decrease and get lower as we get older. So there's a lot of physiologic reasons why sleep is prone to be more fragmented with aging. So those are objective findings, but I want to just transition now to a couple of slides on the functions of sleep. This has been a scientific mystery for many, many years, and this is a great quote. This is Allan Rechtschaffen from the University of Chicago, the guy I actually trained with many, many years ago. who made this quote, which is a great quote. And the truth of the matter is, sleep probably has many functions. These are some of the functions for which there is empirical support. And I've sort of broken them down here by non-REM and REM sleep. There's these two great stages of sleep, and there's not, there's evidence may be stronger for some functions in certain stages than other functions. And I won't spend a lot of time talking about this. I'm really going to focus on just one that's gotten a lot of popular press, but I will say, very simplistic function. If a function of sleep would be to stay out of trouble. If you're asleep, you're not going to get involved in a lot of problems, or you're not going to be eaten by predators, and that's a very simplistic view of what sleep is. But there's evidence for all of these. But what I want to talk about a little bit is one that's gotten a lot of, I think, popular press in recent years. And for those of you who have some science background, I'm going to give you a digress with a couple of slides here that you might find of interest. This is the notion of glymphatic drainage. What does that mean? It means that the brain in recent years has been understood and recognized to have a glymphatic or a drainage system, which really wasn't appreciated 20 or 30 years ago. And it really, this whole model of what sleep might do, very intuitively pleasing, if you will, that somehow the brain gets flushed during sleep. And this goes back to a well-known paper, a great paper published in Science about 10 years ago. Those of you who are interested, I would certainly encourage you to look at this if you have scientific background or you're interested. But for those of you who may have a little bit of background in the basic sciences, it starts with glia. Remember, there's neurons, which are the nerve cells in the brain, and these are surrounded by glial cells. Glial cells provide the nourishment and the support, and as it turns out, provide a drainage pathway for neurons. And so this is the whole concept of what happens with this lymphatic system. The brain is not thought to have a lymphatic system, but this lymphatic system through the glia is a really important feature of how the brain works. And one current theory of the function of sleep is that this system is engaged. So I'm just going to spend half a minute talking about
Dr. Bliwise?
Yes.
I apologize for interrupting you. You're on quite a roll there. We've had some people say that your voice is a little muffled, and I thought it was my computer. I know you've got significant limitations in your equipment there, but we just wanted to check if I don't know if you could move closer, or maybe something's in front
closer. I don't know what else I can do to try to.
That's a little. I think that's a little
better.
Better, yeah. We can see more of your face, which we like. Yeah, thank you.
Well, whatever. Okay. Well, I'll lean in a little bit, and I'll talk about this the mouse brain here. But this is part of this research paper in Science that I mentioned to you. Basically, what they do is they inject a tracer in the brain, this green fluorescent tracer, and they watch what happens as the animal falls asleep. And what happens is the tracer gets flushed. And this is over the course of sleep here. The orange line is the awake state. The sleep is in green here. And over a period of 10 to 20 to 30 minutes, the tracer gets picked up and it gets flushed out. And so this is this whole notion that sleep is associated with drainage in the brain. It's intuitively pleasing, but in fact, until this study came out about 10 years ago, we really didn't have any evidence that this is what sleep did. So there's still a lot of new findings coming out, very interesting findings, and this is one of them. I'm not going to spend any more time talking about this, but for those of you who like basic science, I would encourage you to read a little more about this. It certainly is a very provocative function of sleep. Let's move to the more relevant human issues. What happens when we can't sleep, and what do we try to do about it? And here I'm going to focus my talk on treatments and sort of get sort of practical, perhaps a little bit of, in terms of how do we try to deal with sleep problems in people when we see them. So first off, I'll talk about medications. There are many, many medications that have been tested for use in poor sleep. And this gives you an overview of some of the older medications which fell into this benzodiazepine class. And then there are some of the newer, or relatively new Z drugs. This, by the way, zolpidem is Ambien. Most of you have heard of Ambien. These are non-benzodiazepines, but they work on a similar system in the brain. There's a melatonin agonist down here. And then there's the newest kids on the block. And these are sleep medications that are called orexin antagonists. I'm not going to go into the details of what they do, but they work on a different, unique kind of peptide in the brain. This peptide was only discovered about 20 years ago. And so as soon as it was discovered, the pharmaceutical industry decided, if this is involved in the regulation of sleep, let's try to have medications that might affect it. We don't know for certain. These medications might be better in the long run than some of these others, but we don't know for sure. But there's lots of medications out there that are used for sleep. And these are their chemical names. I'm not going to go through the trade names. It's just not really appropriate in this talk. But what are the issues with use of sleep medications? Well, there are risks and benefits with use of the medications. Let's start on the positive side. Let's start on the green part of the slide. The medications usually work, at least in the short term, and they probably are more effective than over-the-counter medicines and various supplements. They have a range of what we call half-life options. Some are absorbed quickly, and they're excreted quickly. Some stick around in the blood for longer periods of time, which may help people stay asleep longer. And there is good evidence that they're better for sleep than low-dose antidepressant medications, which are sometimes used. So there's a lot of benefits, but there are risks associated with sedative hypnotic class drugs as well. The main one, I would say, is that they become less effective over time. The word we use for that is tolerance. People become, quote, tolerant to the drug. It becomes less effective if it's used every single night. And so a lot of the times when we use sleep medications, we encourage people to take a medication every third or fourth night. When they really need it, after a couple of really bad nights, then they can take the medication perhaps and they'll use it and it'll maintain its efficacy over time. There are other risks, particularly with a geriatric population. We always worry about falls and balance issues, particularly, for example, with nocturia. If an elderly person is getting up 3 or 4 or 5 times a night and they're taking a sleep medication, you're increasing the risk perhaps of falls. And there are many studies that have shown that this class of medication seems to enhance risk for falls. Whether those newer medications, the orexin antagonists that I mentioned at in the end of the preceding slide, whether those are associated with falls and balance problems, still not all that clear. So they might be safer, but we're not absolutely certain about that yet. Other odd things have been reported with sedative hypnotic class drugs. There are case reports of people who get in the car and drive and other odd behaviors which have occurred. We have rarely, occasionally seen them, but they tend to get, I think, blown up by the press to some degree, and they're not all that common. And there's a little bit of evidence, epidemiologic evidence, that higher mortality rates may occur in people who use sedative hypnotic medication often, all the time, but not so much with intermittent use. So to try to give you some overview of the benefits and the risks of this class, these kinds of medications in this class. That's why I've shown you this slide here. What about melatonin? I always get questions about this. Melatonin, of course, you can buy as a supplement, as an over-the-counter product. And these are just two papers which have come out in the last few years that have shown that there is some evidence that melatonin does improve sleep. And we often do recommend melatonin instead of a prescription drug for people, but I want to give you a few other points of view on this. First of all, not all melatonin is created equal. And this is a paper that came out a few years ago where they went into a health food store and they literally bought 20 different brands of melatonin, and then they, with mass spectrometry, they examined what the melatonin content was in the product. And it could vary a great deal from minus 63% less to 478% more. So this just means if you take a melatonin pill, you don't quite know what you're taking. And it could be less strong, it could be more strong than what it's supposed to be. Sometimes, although rarely, there's been contaminants associated with melatonin. And this appeared in JAMA a few months ago. So many people are using this supplement now, and sales of it are so high that there begins to be concern, perhaps, that people are over using it, or it might not always be as safe as we think it is. So just a few comments about dietary supplements. Dietary supplements are not regulated under drug law. They're regulated under food law, and they have a whole different set of standards that are much less stringent than prescription drugs. And so a lot of people take supplements, and there are papers coming out all the time that sometimes there's ingredients that shouldn't be in these supplements that are there. And from just a historical point of view, this is because in 1994 we have a law called the DSHEA Act, the Dietary and Supplement Health Education Act. Orrin Hatch was the author of this, and this gave great leeway to the manufacturers of supplements. As long as they claimed they were not curing a disease, they could make claims that this would improve your sleep, for example, for melatonin, or improve other functions. And this really fell, again, under food law and not drug law. I've seen in recent years from the FDA some indication that there may be some changes coming here, but it will take a regulatory perspective to get better, more control over supplements that people take. So I'm not telling you not to try melatonin, but I'm saying be careful when you take it. And if you find a formulation that works for you, stick with that brand. But it's very much an open area at this time. So I've talked about prescription drugs and I've talked about supplements. What about behavioral approaches to poor sleep? I think this is very important and probably overlooked. And we sort of absorb, we think of sleep disturbance and insomnia with this 3P model. And the 3Ps are predisposing factors, precipitating factors, and perpetuating factors. Let's work our way across. Predisposing factors, some people are just born to be lousy sleepers. And we often, in sleep clinic, will take a history. How did you sleep as a child? What was your sleep like? Some people just have always slept poorly. And so there may be predisposing factors. People are more anxious. Maybe their sleep system just isn't as good. There are twin studies which actually would demonstrate this as well. So some people sit closer to the threshold, if you will, for poor sleep. Then there's often precipitating factors. This can be a psychosocial stressor. It can be travel across time zones. It can be loss of a loved one, a change of job, a new home. It could be a dozen things. but often insomnia is associated with a precipitating event of some kind. Sometimes it's a hospitalization. Didn't have sleep problems till they go into the hospital for a hip replacement and they come home and they never can get their sleep back again to the way it was. So there are different precipitating factors, but most important behaviorally are the perpetuating factors. And this is where we really focus a lot of behavioral intervention. We really focus on what's sustaining the poor sleep. And often people with chronic insomnia spend a lot of time in bed being unable to sleep. In other words, they're so concerned about making up for lost sleep, they spend extra time in bed. And that's counterintuitive. It's counterproductive. It's from a Pavlovian dog model. It's like classical conditioning going the wrong way. If you're in bed, you should be asleep. And if you're not asleep, then get out of bed. And that's a very simplistic approach that we take, but I'll highlight that in the next slide. We're talking about behaviorally based treatment. This is really a fundamental aspect of behavioral interventions for insomnia. If you can't sleep, get out of bed and do something else. That doesn't mean go on the internet or enter a chat room. It means do something relaxed, out of the bedroom, get out of bed and try something else. Try reading, I can go on and on about different things to do, but that's a very important behavioral intervention. There's also obvious things like don't drink caffeine at night. If your bedding isn't comfortable, if the room temperature is too warm or too cold, but often too warm tends to disrupt sleep, that's something to be concerned about. There are treatments that involve deep breathing and relaxation, meditation type techniques. These will work. They work better in some people than others, but they do work to promote sleep. Again, restricting time in bed. Don't spend too much time in bed and avoid daytime naps. I always use the analogy of gas in the tank. If you use some of that gas up on a short trip, like a short nap during the day, you'll have less in the tank at night. So we try to get people, no matter how tired they are from having slept poorly, to not nap during the day. And then physical activity and daytime light exposure have been consistently shown to improve sleep. So there are behavioral things that one can attempt to do to try to improve sleep. And this is just sort of an overview of some of them. Finally, on this, just to emphasize this point, this was a randomized clinical trial that looked at what we call cognitive behavior therapy for insomnia, which is essentially what I just described to you, a pharmacotherapy, a prescription drug for insomnia, a combination of the two treatments, and then a placebo group over here. And these are the time periods here: pre-treatment, post-treatment, follow-up at 3 months, follow-up at 12 months, follow-up at 24 months. And the y-axis here is how much time people are awake after they fall asleep. So the higher this number, the worse the sleep. And you can see cognitive behavior therapy and pharmacotherapy seem to work pretty well at first. And of course, the combination does as well post-treatment. But look what happens 24 months, the gray bar here after treatment is done. When you do cognitive behavior therapy, people learn to sleep better. You can condition yourself behaviorally to sleep better. The pharmacotherapy group doesn't show that. They revert back to poor sleep after 2 years. But there's something to be said for behavioral interventions for insomnia. And I won't talk any more about this, except this is a great study published in JAMA over 20 years ago, which showed that behavioral interventions for insomnia work. Let me sort of end the last part of the talk on specific disorders of sleep that we often see in the sleep clinic. To talk about these a little bit. Sleep disorders in medicine is a whole area unto itself. It's actually a medical subspecialty. It's a there's board certification available for MDs who are interested in this, and they can enter this subspecialty through internal medicine, through neurology, or psychiatry. And this just gives you a brief overview of the kinds of disorders that one can see in each of these different areas. So sleep disorders is a really complex area. And I want to talk about a few of the common disorders that we see. RLS is certainly one. This is a movement disorder, which is characterized by an urge to move the legs, a sort of sense of discomfort in the legs that are worse at night. Whenever someone is still, they seem to come on. They're improved with movement. Urges is sort of the acronym that we use, worse at night. And they're not related to, for example, neuropathic pain. And so our RLS is a major sleep disorder, very common in the population, that can cause insomnia. It's most common in people with Northern European background, interestingly enough, less common in Asian populations, less common in African populations. Women tend to have more of a greater risk for it than men. And it seems to increase with the number of pregnancies that women have had. It is treatable. There are medicines that we use for it. This just shows the prevalence in an elderly population. These are different studies that have been done. This is the prevalence over here. These are different populations throughout the world, but in some older populations, 15, 20, 25% have a form of this symptom. So this is a treatable condition. Often the bed partner knows about this too, because the person with the restless legs picks their legs all night. And this is an example of a polysomnogram that we do in the sleep lab, which shows a lot of leg kicking, so-called periodic limb movement, periodic leg movement here, which occurs overnight. And often the bed partner is a good source of information about this. I want to talk about sleep apnea now, very common sleep disorder. I'm sure there's some people on this call who've been diagnosed with sleep apnea. Not to get into too many technical details, but there's really two key components to sleep apnea. One is that your sleep is interrupted by being unable to breathe. And every time you don't breathe, you wake up. So there's fragmentation which occurs because of the inability to breathe at night. That's one component. The other component is if you don't breathe, your oxygen saturation down here begins to fall. And so these two components are really key. And a lot of times patients with sleep apnea come to us with symptoms related to not only snoring and gasping during the night and struggling to breathe, but being very sleepy during the daytime. That's because they're waking up all night long, sometimes hundreds and hundreds of times every night. The metric that is often used is something called the AHI, the Apnea-Hypopnea Index, and this is a rate measure. It's a very simple concept. It's the number of breathing pauses that one has per hour of sleep. If this number, for example, is 50 or 60, that's very severe. That's severe sleep apnea. That means 50 or 60 times every hour, your breathing stops and you wake up 50 or 60 times an hour. Imagine being awakened 50 or 60 times an hour. You're going to be very sleepy the next day. The prevalence of sleep apnea increases with age. This is an AHI of 15 per hour. You can see the prevalence goes up with age. Interestingly enough, while in younger people, body weight is very important. This is just a graph showing that the impact of body weight goes down as we get older. So the prevalence goes up, but the impact of being obese or being heavy goes down. And that's because the factors that enter into sleep apnea in old age are a little different. They involve weakening and lack of strength in the airway muscles, just like we lose strength in muscles in our legs and our arms and our back. As we get older, the muscles that line our airway get weak as well. So body weight in younger people, yes, being massively overweight is a huge risk factor for sleep apnea. But in old age, there are other factors that may occur. Of course, CPAP, continuous positive airway pressure, is the mainstay of treatment. There are other treatments. I won't go into them in the course of this talk, except to mention that actually I'll come back to that. There is a mandibular advancement device, which is a mouthpiece that's worn. This is an alternative for CPAP. But just to hit upon this, actually, those of you who get the New York Times, Science Times yesterday had a whole story about the recall of CPAP machines. One of the major manufacturers of CPAP machines had to recall their devices. It's a big problem. They have 5 million CPAP machines being recalled in the United States and worldwide. I won't go into that except to say that if you own Philips stock, it's gone way down in the last year and a half. So CPAP remains a mainstay of treatment. There's a lot of advertisement now for this device called Inspire, which is actually a surgical procedure, which there are leads that are implanted through the neck, and they stimulate the muscles in the upper airway when you sleep. So the commercial doesn't quite do this justice. It just says, are you struggling with CPAP? But it doesn't really describe that this is a surgical procedure that's now often used for sleep apnea as well. I want to end with one specific sleep disorder, which you may not have heard of. It's called Rapid Eye Movement Sleep Behavior Disorder, or RBD. And I'm going to show you a video of several patients who show this. What this disorder involves is acting out dreams. When we go into REM sleep, normally our body becomes atonic. We lose muscle tone. We're relaxed. Our brain is very active, thinking different thoughts and dreaming and so on. But our body is relatively paralyzed. But what happens if the body is not paralyzed? And what happens is this. So this is going to run for about 1.5 minutes. It's going to show different patients, and I'm going to talk over it. There's no sound. I'll just talk. This is a gentleman, middle-aged gentleman, older gentleman, probably in his 60s. And when he goes into REM sleep, he acts out his dreams. He's thinking about fighting, hitting. A lot of these patients have dreams of combat if they were in the military, but not always. All the cases I'm going to show you here are men. Women have this too, but not quite as frequently. This is not seizure. These are not seizures. These patients are, during the daytime, they're caught. Look at this guy here. He's throwing his arm like that. If you were the bed partner there, you could really get injured. And it's a serious disorder that we encounter in the sleep lab. Often it's difficult for the bed partner because the patient may not even know that they're doing this. They're acting out violent dreams. And this is called REM behavior disorder. It's a reason to be seen in a sleep clinic. It is treatable. In some cases, not all cases, in some cases, it anticipates the development of Parkinson's disease. Not always, but in some cases it does. And I just wanted to give you a little sample of that. So I think we'll go on to the next slide. And that is the end of my talk. And I guess we'll take questions in the chat now.
Yeah. Thank you, Dr. Bliwise. We do have a few questions.
Yeah.
Those videos were a little disturbing, so we'll have to get over that.
Okay.
Obviously, melatonin is popular, and we had questions on that. And
Sure.
I'd seen that study too, that supplements vary not only by brand, but as you noted, in different batches.
Yeah.
So you can't even really trust a brand because brand could be different when it was made. But is there any way to check the ingredients as a lay person, or to know?
Yeah, the short answer is no. I think you're better off if you buy a sort of a brand that's a little better known, I think. And I would say, even though you're absolutely correct, Andrea, that the batch can vary from batch to batch. If I find a brand, or patient tells me that this brand works well for example, there's something called the Life Extension brand. It's just a brand name. I tell them stick with that brand because you're more likely to get a consistent product at a consistent dose. But for example, some people will tell us, "Oh, I took a melatonin, I was knocked out for 24 hours." You know, well, given the fact that it could be a 470% difference in dose, you know, maybe you picked the wrong brand. You know, so no, I can't. I'm like there's no easy way to test this short of bringing stuff to a lab.
Thank you. And we had questions about magnesium and CBD products. Magnesium is often promoted as helping sleep. Have you seen that in the Emory sleep?
Scant evidence. A couple of not particularly well done clinical trials suggest that magnesium. Some people think magnesium is good for RLS, but if your magnesium isn't low, then I'm not sure that it would be all that helpful. I would say the evidence, for example, relative to melatonin, which those studies are well controlled and the melatonin is pure, the number of studies of magnesium supplementation to improve sleep are very small and not all that well done. So that would be an open question. In terms of CBD products, yeah, you know, there's evidence that seems to work well for sleep. Again, you know, that's going to vary a little bit by what's available in states. And again, it's not regulated, you know, the way a prescription drug is. So we don't generally in our clinic recommend it, but an awful lot of patients have told us that they try it and it works for them. So yes, there's probably more evidence, good evidence for CBD products relative to a lot of other supplements as far as sleep's concerned.
And another question that probably affects half the population, menopause seems to disrupt sleep. Is that something you see a cause and effect or just comorbidity or?
Yeah, so that's a great question. Yes, the descriptive observational evidence is pretty clear that during the transition to menopause, there's a great increase in the prevalence of insomnia in women as they go through menopause. What is much more up in the air, and which I'm not going to offer advice on, is whether hormone supplementation replacement therapy is useful for improving poor sleep. There's actually a little bit of evidence that it does, but there's so many other factors to weigh in that every woman needs to check that out on her own with her own doc. You know, there are issues of cancer and heart disease and so on. And so even if hormonal replacement therapy did help sleep, there have to be other considerations taken into account. But yes, menopause is certainly a well-known factor. And we see many, when I talked about precipitating events in women, that is often a precipitating event. A woman has slept well most of her life. She goes through a change of life in menopause, and all of a sudden she doesn't sleep well. So it's not uncommon. That doesn't mean some of the behavioral approaches that I've talked about here might not work. So increasing physical activity, outdoor exposure to light, and by all means, not napping during the day. If you've had a lousy night and you're tired the next day and you nap, that reinforces and it reduces the homeostatic pressure for sleep at night, and you're more likely to sleep poorly the following night.
Okay, and thank you. That was very helpful, and I'm glad you reiterated that each individual should have a discussion with your healthcare provider. I mean, that I think that applies to every question and every answer. You know, Dr. Bliwise can give generalities based on his extensive experience in the research in the sleep clinic, but everybody is different, literally. Similar question on menopause with Alzheimer's. is there a connection between Alzheimer's and sleep? I don't remember if it was on your first slide.
Yeah, no, that's a great question. It's a very hot research topic, and one that I've been involved in for a number of years. So the traditional perspective, this is going to be a long-winded answer, but if I go too long, you can cut me off. The traditional perspective has been that Alzheimer's disease causes poor sleep. That the neurologic condition itself leads to, deterioration in the brain, some of the centers that control sleep. And so it's a consequence of Alzheimer's. I think the more fascinating question is, could poor sleep predispose to the development of Alzheimer's disease? So if we go back to the basic science, the little few slides I showed about the glymphatic drainage, if sleep serves a vital function to drain the brain from unwanted toxic wastes, if you will, if sleep is impaired, might that drainage system be compromised in some way? It's really an exciting, provocative thought, and you can read a lot of popular press about this, and a lot of scientific papers as well, that imply that sleep could lie on the causal pathway. All I can give you here is my opinion on this particular area. It's a complicated area. The evidence, once you really get down to nuts and bolts, isn't all that clear that disrupted sleep causes or hastens Alzheimer's disease. I showed you, the prevalence data, right? 50, 60, 65, 70% of a population above age 60 has poor sleep. Not all those people develop Alzheimer's disease. That's, one broad brushstroke overview I can give you. So there is some evidence. I can't say there's not. There's been review papers and meta-analyses that have tried to show that, that have claimed to show that. The other sort of thing that is inconsistent with this is, okay, if that was the case, then treating poor sleep, should improve that, right? You should stave off Alzheimer's disease if you have someone who sleeps poorly and improve their sleep. No one has ever shown that. And it may be because we have to treat, sleep disturbance for 5 or 10 years in middle age to prevent the development of Alzheimer's disease 20 or 30 years further down the line. But it's a complex question, and I can go on, but I probably shouldn't. I think the evidence is still open on that particular point, but you will read and hear quite a bit about that. And the basic science stuff, it really starts with that, because this whole notion that the brain drains itself of toxic waste during sleep is sort of where that starts.
Thank you.
Yeah.
Thank you. Yeah. And I think you've given us a lot of good guidance for our members of, if you're seeing these things or feeling these things or concerned about these things, have it go checked out. I think we've got time for 1 or 2 more questions. You hit back at the drainage, and that was a question early on. Can you give us another 30 seconds on the glymphatic drainage and what is draining out? I think that's when we were having a little bit of trouble hearing, and it was a little bit technical.
Okay. It's quite technical. When you read a paper in science like that, it can take you like all day to read it because there's so many details to it. What the investigators showed is that by injecting a dye, that dye in one region of the brain, they showed clearance of that dye during non-REM slow wave sleep over a period of about 20 minutes. And that didn't happen when the animal was not asleep. And the key feature of those studies is that this was active transport. In other words, it didn't fit a model for simple diffusion. that it wasn't simply a matter of the tracer diffusing across brain tissue. It was active transport, and that's the key concept. Now, there are a lot of things about that model that it's not a comprehensive model of sleep function, because if you read the paper in detail, they saw the same thing with anesthesia. So they got the same brain drainage during anesthesia that they did with natural sleep. Well, anesthesia and sleep are related, but they're different. We talk about people being put to sleep or going to sleep for surgery. That's different. It's a different physiologic state, but their model really works the same in non-REM sleep and in anesthesia. So there's got to be something else that goes on to differentiate those two states. Another feature of the drainage system is it doesn't describe REM sleep. The paper is completely silent on REM sleep, and yet REM sleep is a vital part of the sleep cycle. Remember the sleep hypnograms that I showed. It occurs every hour and a half. You have to have non-REM in most people before you have REM sleep. REM sleep is a very vulnerable state for breathing, for temperature control, for a lot of things. It must serve a vital function, but lymphatic drainage, we don't know how REM sleep has anything to do with that. So there are a lot of aspects of it. And then the other thing in terms of this, the Alzheimer's hypothesis is these investigators did not show that misfolded proteins like beta amyloid or tau, which are the characteristic proteins that go haywire, if you will, in Alzheimer's disease. This study never showed that those misfolded proteins get drained. They showed a proof of concept that there's active transport of a tracer during sleep, during non-REM deep sleep, but that's what they showed. So again, I would, if people on the call have background in basic science, read the paper. It's really interesting. It was in Science in 2013, and I guess you'll have this archived. This talk will be archived, so you can go back to it and read that. But yeah, I don't know. I probably shouldn't talk any more about that at this point.
We're gonna wrap up on a very popular topic. I say popular. I don't know that it's well liked, but popular. And then we'll wrap up. Do you have any thoughts on daylight and standard time and or is that too hot of a topic? Should we?
I'm not sure. Here's my read on that. I think the biggest issue is changing the time, changing whether we go on permanent daylight or permanent standard. I think the shifting is not good. And there's a lot of evidence that when we lose the hour of sleep in the spring, that there are more bad things that tend to happen. There's more accidents, there's more heart attacks, there's all kinds of bad things that occur because of the shift. Now, but that doesn't answer whether we should be on standard or permanent daylight savings. And there's lots of arguments either way. A lot of this involves policy, school starting.
Yeah, we can't. We're not gonna be able to solve that today,
right. But
we appreciate.
My biggest concern would be anything shifting is probably not good. There's some evidence that that's not a good thing for the population to suddenly get an hour less sleep.
Well, thank you. Well, Dr. Bliwise, this was jam-packed of really helpful information. It's given us a lot to think about if either we or a loved one or a family member or a friend is having sleep issues. And you've given us a lot of directions to at least start looking and investigating and talking about with our healthcare provider. I want to thank our membership. The questions were fantastic, very meaningful, things that affect a lot of people, intellectual as always. We have the most incredible members.